Hello, my name is Daniel Stillwell. I am the editor of the IFTA e-newsletter, and we are here at IFTA in Spain with Hannah Sherbersky, Shan Tate, and Sarah Helps. They're all from the UK, and we are going to talk about their work, who they are, what they're doing, and kind of an overview of what family therapy is like in the UK these days. So thank you all for being with us.
Pleasure.
So let's start off with professional identities first. We work with people all over the world, and therapy or systemic psychotherapy looks different in different places. So what kind of mental health practitioner do you identify as, and what does that look like where you work? And anyone can start.
Shall I start?
Yeah.
So I'm a clinical psychologist as well as a family therapist, systemic psychotherapist,
Mhm.
as we tend to be called in the UK. And so I work wearing two hats really, as a clinical clinical psychology hat and a family therapy hat. What that looks like in my clinical practice is primarily at the moment working in a neonatal intensive care unit. So my identified patient is usually a very premature baby. And the system I work with is the caring system around the baby. And when I say around the baby, often the sessions happen around the
Literally.
cot, because that is where families want to be when their babies are incredibly sick. So I work with the infant and the parental caring system, and then the extended family, and then the ward-based systems.
Wow, okay.
I worked in our health service where a lot of family therapists are employed as family therapists or as family and systemic psychotherapists, to use our full term. And so I worked eventually in a senior leadership in that role in child and adolescent mental health, but semi-retired and now work more independently and also do a lot of supervision. But probably my route in that reflects quite a lot of other practitioners in the UK, that a lot of people are, all doing both at the same time, working independently or in the health service, but we also have people working obviously in in the charity sector, but also in social care, embedded in social work, along social work social work teams.
So I originally trained as a mental health nurse and worked in inpatient psychiatry for a number of years before I then trained as a family therapist. And I worked then as a family systemic psychotherapist, predominantly in child and adolescent mental health, like Shan. And particularly I worked for 9 years in an adolescent inpatient unit, so a hospital, psychiatric hospital. So that was my main area of clinical work. And then I went on to work more as an academic, and I guess we'll go on and talk about other roles in a second. But I still work a little bit in private practice.
Good.
Because we have to for our own accreditation. So to continue practicing and to be registered as a family therapist in the UK, you actually still have to be working in clinical practice.
Nice. Yes, in the US that's not always required. And as someone who's been in and out of academia, you lose a little of that grounding if you don't stick with it.
Exactly.
So why don't we start with you then? What other professional hats do you wear that are connected to all this?
Yeah, so I'm an associate professor at the University of Exeter, which is in the southwest of England, and I'm the deputy director of a clinical training department that sits alongside sits within the psychology department, but we don't train clinical psychologists. We deliver all the training for postgraduate taught programs. We have about 30 credit-bearing courses. So these are trainees who are not training in family therapy necessarily.
Right.
They're training in other roles and courses, primarily funded by our health service. So we have over 1,000 students a year training with us. So it's a huge department. It's very clinically active. The people who are working within our department, we have over 100 staff, are all clinicians. So many clinical psychologists, family therapists, senior nurses. So it's a clinically applied centre of excellence. We deliver training regionally but nationally as well. So we're nationally recognised as one of the training providers for many low intensity and high intensity treatments for various different mental health difficulties. And within that department, we have a systemic portfolio of training where I'm also the co-director with my colleague Mark Rivet. And in that portfolio, we have another 7 programs of systemic training, which include all our levels of family therapy training, intermediate, foundation, intermediate, qualifying level, and also supervision. And we have increasingly now a number of training programs that are working with systems, which is very exciting. So that feels like a real innovation. So family therapists laying claim a little bit to developing whole team trainings.
Nice.
For hospitals, for supervision. We have a number of programs that sit within that part of our portfolio that we describe as systemic because they're about working with whole teams.
Mm-hmm.
And so that's one of my jobs, and the other job is I'm the CEO for the Association for
Right.
Family Therapy and Systemic Practice.
Mm-hmm.
So I'm obviously primarily this conference I'm sitting here with that hat on.
Mm-hmm.
As the new CEO, and that's a part-time role, so I do both of those 2 roles.
Okay, thank you.
Yeah.
And perhaps I'll start off on that from the professional body, the AFT. I've been a former chair and hold a number of voluntary roles currently, working with them as coordinating the research group, the conferences and webinars I'm
Mm-hmm.
involved in, and particularly where it relates to IFTA, I'm on the IFTA board as a member, as the treasurer, and IFTA board as well as part of the national associations representing them in IFTA, the European Family Therapy Association. And I think that was important to AFT, the UK
Mm-hmm.
organisation, when I was chair, was to locate us back in our bigger networks.
Mm. Wonderful.
Mm.
And Sarah?
So in terms of my professional link with AFT, I'm the new Journal of Family Therapy Editor-in-Chief. It's a role I've been fully in since January, although the lead-in time was about 6 months, which was really, really helpful. So my ambition for the journal is to carry on the really good work that's been going on with the past 8 editors, and to really push for research and theory and practice papers that are fully mindful of a social justice agenda and an inclusivity agenda. So I'm very interested both in revisiting old papers through contemporary lenses, but also thinking about the populations that we're researching with rather than researching on, and thinking about how to expand the diversity of the range of authors that we publish. Those are key issues for me.
Wonderful.
More generally, in terms of professional identity, I teach on courses, clinical psychology training courses, where systemic perspectives are being increasingly embedded, so that clinical psychologists come out of training in ways where they have very good systemic skills, not to qualifying level, but still good systemic skills. And I also have a role teaching on a course around consulting and leading in organisations. And my role there is to bring a systemic perspective to an otherwise psychoanalytic course.
Okay, nice. Now, you're not just here to be fancy people from the UK. You also gave a presentation here at IFTA. Tell us a little bit about what that presentation was and takeaways that people would enjoy hearing about.
Maybe one of them is, we were talking about the professional body and how family therapy, where it situates itself in the UK. So, and in the different contexts that people work in the UK. But I think perhaps one of the things to talk about is our training, is that it's largely based on people having a first health profession in health and social care. There are ways to APEL to have an equivalence to come in, and that's important too. But it's our prime way through is by being perhaps a social worker, a psychologist, a psychiatrist, a nurse, a teacher with a pastoral role, so that there's we're already building on those different professions. And I think it's more than that's just a route into the actual work. I think that influences us in terms of how we work and how we we bring those different perspectives together. I think it's a really important ingredient, that multi-professional first core profession.
Right.
Yeah, and an experience in working in statutory services. And
Yes.
that's the other kind of, because of the nature in the UK of these prior professional qualifications, the majority of people coming into family therapy training have got a really good grounding in usually mental health, but also working in statutory services, managing risk, doing assessments, understanding how those kinds of statutory services work, I suppose, before they've even entered into the final 2 years of our master's level qualification. So I think it does, coming to these kind of conferences is always so helpful, isn't it? Because sometimes we understand ourselves better when we're defining ourselves by what we're not.
Yeah.
And sort of looking around and trying to make sense of and understand our family therapy, our global family therapy community, I think really helps me to recognise how incredibly fortunate we are in the UK. Firstly, because of our welfare service, our NHS, our National Health Service, but also how over many years I think family therapy very quietly actually has been building a kind of ground force of work in the NHS and in the third sector and social care as well, actually. And family therapy has got a very strong connection with social care, so social workers, there's a lot of family therapists were social workers before they come into the profession, and a lot of the family therapists go back into their social work roles or of some description or other, taking some of those systemic skills and ideas with them.
As well as working alongside teams of social workers as family therapists.
Yes,
Right,
exactly. And in the UK, being a family therapist is a designated, recognised role of itself. So, and I think the general public have quite a good understanding of that. Many people in the general public have heard of family therapy,
right,
and know that it's something about seeing a family. They don't perhaps know very much about it. But it's certainly out there in kind of people's general realms of understanding that there is something called family therapy that you might be able to access, often through the health service for free,
right.
Particularly if you have a child or a young person who's in difficulty. Harder if you're accessing through adult mental health. There are less family therapists working in adult mental health, but it's increasing actually. So, yeah.
And I think, so just listening to what you're saying, I think the role of the journal is to provide and to contribute to the underpinning evidence base, so that services continue to grow in child and adolescent services and across the lifespan, really.
Yeah.
I think for the global audience, one thing that's been brilliant about the conference is hearing what's going on around the world and thinking about all the stuff that we don't have access to in the UK that's happening elsewhere. So for me, receiving journal articles that describe practices in different contexts, in different ways of delivering services is really helpful, because it can help us with a slightly more UK focus grow the ways in which we can develop services, deliver services, and so on.
Wonderful. Yes, I have heard people talk about the shift from evidence-based practice to practice-based evidence. How is that being discussed in the UK?
I think it is being discussed. I think we're still not quite getting there in terms of having that research recognised in the sort of at the governmental level.
Right.
I think it's very valid at the practice level, and I think it's important. It's incredibly important. But of course, often where the status is RCTs, and sometimes arguing for posts on that basis, we haven't got enough evidence.
Yeah, I mean, we certainly don't have the kind of scale of research that's been conducted in the USA by any stretch. But what's interesting is, despite that, there is still a body of evidence that our NICE, National Institute for Clinical Excellence, draw on. So they are the kind of governing body. They make recommendations about all medical treatments, not just mental health, in the UK.
Nice.
And actually, it's interesting that despite the fact that we don't have these huge RCTs and we don't have the same level of research activity, I think, within our family therapy community, we still have a very strong foothold into a lot of important work. And if you think about the kind of history of research in family therapy, the two areas where there's the most money going into family therapy provision at the moment are eating disorders and psychosis. And those are the areas that were originally researched and considered by people like Gregory Bateson, right? And Salman Minuchin. And they're still, actually what's interesting is those are still the areas that family therapists have the greatest sort of input into in the UK, which is kind of interesting, isn't it, that we haven't moved that far away. So there's a lot of work to be done, and we were talking in our workshop a little bit about our family therapy community and the kind of ongoing discussions about what constitutes evidence and what constitutes research, and how to hold a both-and position around that, and how to be research savvy whilst being able to critique some of the processes and the power structures and institutions around us. All our qualifying level courses expect people to qualify having conducted some type of research. Sometimes it's a full-blown piece of research, it might be a systematic review or something like that. But I think there's still an ambivalence about academia even, that we're always striving to try and get more family therapists involved in writing research, being more research active. It often falls into the kind of psychology field, more so than family therapy. So I think there's work to be done there, isn't there? And lots of us are involved in lots of those conversations about how we push that agenda with our community.
Using outcome measures, of course, would be fairly standard, particularly in the health service. And we have developed, some colleagues have developed what we call SCORE, and that is translated into a number of languages, and there is a SCORE app. So people are increasingly using that to evidence their work.
Yeah, people can find out about that actually on the IFTA website. There's a whole series of videos and resources that are freely available for people interested in looking at that.
Even the common factors movement that, I guess, I don't know if it started in the US, but certainly got bigger there, starts with the fundamental question of why does this work? And, I don't think it always has to be the most sterile of RCTs to find useful truth. Maybe not the answer, but there are these nuggets, and so you have your different forms and venues to answer and perpetuate those answers.
Yeah, absolutely. And there have been innovations in the UK training programs, something called CYP IAPT. So some people might have heard of IAPT, which has been a big, there's a huge amount of money that's been invested over many years in improving access to psychological therapies. And one innovation, Child IAPT, came about 11 years ago now, and that included, so that was primarily CBT and parenting teaching and some other strands, but it also included some systemic teaching. And there's been a lot of investment and money and energy gone into training people. These are people who aren't qualified, but they're trained to an intermediate level to be working systemically with young people, particularly with eating disorders or who have got depression, self-harm, conduct disorder. And that's been very much informed by the evidence base. And we've worked with wonderful colleagues from the US, like the team from Drexel University, Guy Diamond and Suzanne Levy, on ABFT. They contributed to that curricula. That also included our colleagues from Maudsley, FTAN, and we teach actually FTAN and FBT, family-based treatment, as well. So, some of these evidence-based or evidence-informed models have found their way into our communities, and it's been very helpful, I think. And there's a kind of flourishing series of ideas and networks of people who are thinking about alternative ways to do research as well, aren't there? Which I think is really exciting. So we're having to encompass all of that, I think, to move forward. We can't be kind of complacent around any of that.
So then let me ask about one dimension of relational therapy that I hear a lot of people talk about, but we haven't talked about today, which is couples or partnerships. As family therapists, especially working within governmental bodies or hospitals, you are working more intergenerationally. But how is where's couples or partnership therapy at these days?
I think most of the relationship therapy happens, unless it's sort of an adjunct to a piece of work within the statutory or the health service. It's more in the independent practice, I think,
Okay.
or in the third sector. A lot
Mhm.
of work goes on in the third sector as well.
Yeah.
But I think, perhaps just take a step back. One of the things that came up in the workshop was there was a discussion of are you still seeing families, or
Mhm.
has that kind of been eroded? Are you just seeing individuals or couples?
Mm-hmm.
But actually, I think we are seeing a whole range of, and particularly being embedded in the health service, it means that we are still having the opportunity to work intergenerationally and to see more members of the family. And of course that can happen in independent practice, but it's sometimes financially less viable to do that. And
Sure.
so it's...
I mean, one of the things that struck me over the past few days is the freedom that we have in the UK to do the work that we think is right for this particular family at this moment in time.
Mm.
So as an NHS practitioner, if I want to see a couple, I can see a couple. If I want to see a family, I can see a family. I'm not constrained by any sort of licensing that tells me I can or can't do a particular thing, and I think that's a real bonus.
You're allowed to set the whole unit as your client.
So the service would have one identified patient, but my relationship to that would be to have a collaborative discussion with the family about what I think is most useful and what the evidence-based practice-based evidence
That's
would
great.
fit.
But I think what you're touching upon there is a really important issue, and just to sort of go back to the question of couple therapy, a colleague of mine and I, Janet Ribstein, developed a couple therapy for depression model maybe about 10 years ago, informed by integrative behavioural couple therapy
Mhm.
ideas and kind of bringing in CBT and other EFT ideas. And we were very excited because in our NICE guidelines there is recommendations for behavioural couple therapy,
Mm-hmm.
but it's very broad, the definition.
Mm.
In fact, the definition I would argue is a systemic one. It presupposes that the dysfunctionality or the depression is in some way situated within the relationship. So it's a very systemic proposition. But no, there was a question mark about whether that work was going to be taken on by our CBT colleagues,
Mm-hmm.
or whether it would in fact be taken on by family therapists who themselves can work behaviourally.
Right.
So Janet and I saw this as an opportunity and developed this model. In the UK, there continues to be a lot of kind of political wrangling about where behavioural couple therapy fits and who's delivering it. But it is actually recommended in NICE guidelines, behavioural couple therapy,
Mm-hmm.
as one of the 4 treatments for chronic and enduring depression. What's been harder is to push our way into that community. A lot of people are offering other forms of individual therapy for chronic depression, and a lot of services don't fully understand the notion of couple therapy. They might only think about couple therapy if there's high levels of conflict, for
Sure.
example, rather than understanding the relationship as being an asset
Mm-hmm.
that you could build on. And part of the reason for that is what you were alluding to, which is the fact that we still within the NHS, or within our whole kind of framework, I think within the UK, struggle to understand the concept of having a relationship as the identified patient.
Mm-hmm.
So all our note systems, all our infrastructure, so even though you're right, we have this flexibility, we still struggle with the idea that that you can have more than one patient at
Right.
a time.
Mm-hmm.
We don't have any way of capturing that in terms of our governance and our data sharing and all that kind of stuff.
So back to my example of my clinical practice,
Mhm.
my patient might be a
Yeah.
28 week
Baby.
baby,
Yeah.
but the work is with the couple.
Yes.
And that it doesn't quite fit with the system because
Mhm.
the system is an individualized,
Yes.
has an individualized focus. It's
Yeah.
really, really complicated.
Right,
Yeah.
right.
Yeah.
And,
Yes.
you have to argue, well, maybe you don't have to make the argument anymore, but in the US, we always have to argue that doing work here still impacts
Yes.
the person,
Yeah.
the IP.
Yeah.
Mhm.
I think within child and adolescent mental health, we have to argue that less.
Okay.
it's in other services that I think we're still, you know, so in adult mental health, in psychosis services, in other health settings, in paediatric services, we're still having to have that argument over and over again.
Okay.
Yeah.
Well, we'll hopefully get there, and so the three of you move the Overton window as you can in the UK, and we will learn from each other, like you said. I love the interdisciplinary aspect of your health service system, the fact that as systems thinkers, you're ripe for leadership and guidance and governance and changing minds. So thank you so much for being here today. Let's end with a little fun thing. So you're from the UK, you're here in Spain. Where in Europe have you not been to, but you know you want to go?
Oh my goodness.
And I promise this is not a political question.
So I can't answer that because my head is in my next leg of my journey, which is going to New Mexico and Albuquerque. So I'm looking forward to crossing the pond.
Well, that is also a beautiful area of the world. So yes.
Yeah, I'm not sure, but I know I'm going as the IFTA representative and the member of the IFTA board to Bulgaria. Our next meeting of all the national organisations in Europe is happening in Sofia in Bulgaria, and I've never been there. It sounds great.
Yeah.
Wonderful.
Wow. I have a hankering for a Greek island. So,
Okay.
I mean, I've been to Greece and I've been to a few Greek islands, but I think the sunshine here in Malaga has really whetted my appetite. So that's where I would like to be headed.
Fantastic.
Yeah.
Well, Hannah, Shan, Sarah, thank you so much for being here with us today, and we'll be seeing you around.
Great.
Thank you.
Thank you.